Okay, in the interest of time, we're going to move right on to the next session, try to finish before lunch. My co-moderator, Mac Macaroon, we're going to move on to current status topics, TVAR dissection. First topic is TVAR. Vicente Riemba is talking about descending thoracic aortic aneurysm.
Thank you, Mr. Chairman. Thank you, Mike, for this very kind invitation. For me, it's a pleasure to be part of this celebration here. And I tried to focus our attention about some kind of current and remaining concerns about TVAR for the descending thoracic aneurysm. So this morning we learned a lot about the history, about the pre-commercial and preclinical experience on that. And for sure we are here because this is a 25th anniversary of the treatment of the descending thoracic aneurysm by TVAR for this particular institution with my host. Our host is Mike Dake. But after that particular experience and many others around the world, started the commercial war. It started in 1997 with a thoracic talent device, and was specific in Western Europe. We have the opportunity to try with a different kind of devices with different brands, especially from 2003 up to 2007. By instance, after 2007, it seems to be everybody is happy, and everybody starts with their own experience, and no new brands reach the market later on. From the clinical point of view, there are so many papers and also some kind of guidelines and consensus documents, but it's quite common if you review all these particular documents, the lack of evidence in order to defend TVAR as a first choice for descending thoracic aorta in front of the non-believers of that. By fortune, with the recent European guidelines for the descending thoracic aortic management, we know that for unfit and fit patients with a favorable anatomy, endovascular repair should be considered the descending thoracic aorta aneurysm for more than 60 millimeters in diameter. Is a recommendation to 2A, but the level of evidence is just B. In opposite, the open repair should be considered for fit patients with descending thoracic aortic exceeding 60 millimeters in diameter who are unsuitable for endovascular repair. And this particular recommendation is 2A, and the level of evidence is even less. This is level C. So, in the conclusion, TVAR is the winner, or at least seems to be the winner nowadays. There are some kind of concerns still related to the access issues, neurological complications, retrograde type A dissection, art conformability issues, branches, and TVAR durability. About the access, everybody here in the audience is aware about these particular limitations when you have limitations related to the access with some kind of accidents. Some of them could be dramatic and even lethal later on. By fortune, all the companies involved in this particular field make an effort in order to reduce the diameter, as Cook Medical, for instance, and another particular trade brands like Bolton Medical, and later on is coming also Valiant Evo from Medtronic. But about the neurological complications, everybody also is aware about the paraparesis and paraplegia issues, the stroke, and even the silent brain infarct related to TVAR technology. For that, recommendations from the European Society guidelines, patients with a planned extensive thoracic aorta coverage more than 200 millimeters in length or previous triple-A repair have a higher risk of spinal cord ischemia, and prophylactic cerebrospinal fluid drainage should be considered as in the endovascular thoracic aorta repair with TVAR. So the level of evidence is, again, is very low, is level C for this particular recommendation. We know from many different kind of authors from the literature that it's very important to prevent the spinal cord ischemia using the hemodynamic stability, using hemoglobin level about 10, and also this spinal fluid drainage and pressure monitoring. And also we need to use the MEP and SEPS monitoring, and temporary subperfusion stage procedure seems to be, so-called precondition seems to be useful, and restore the pelvic and lower limb flow as soon as possible, especially for thoracoabdominal reconstructions, and the reconstruction is also an important point. About the stroke prevention is still a lot of work to do, because they are multifactorial, embolic, even air embolic, hyperperfusion, hemorrhagic, and the start the embolic issue just with the contrast injection in the arch, and also with the stent deployment, that seems to be quite difficult to avoid it. But there are some kind of attempts in order to avoid this particular complication. In some instances could be catastrophic or lethal for the patient. Using the appropriate procedural planning, minimize the wire manipulation in the arch, the necessary manipulation with any kind of devices, and use the heparin for use flushing with CO2 or the device selection, and also avoiding the ballooning. Some kind of filters you can see here in the images are also coming from the TAVI procedures. The TAVI experience could be also promising in order to prevent the stroke issue. Also, the left subclavian arterial vascularization and the use of the branch devices could be useful. And from the European Society guidelines, we know that in elective thoracic grafting cases, the only recommendation we have is when you plan to intentionally cover the left sclavian artery in patients with a risk of neurological complications, even for spinal cord ischemia, preventive left sclavian artery revascularization should be considered. Is a level class. It's a level of evidence, again, is very low, is C. About the reticular type A dissection, we know is brown, and overall is 1.3% when you play with TIBA, which might more often with an acute type B dissection, but this again is multifactorial. This is related to the oversize, the sharp designs, or high radial strength, endograft displacement, the ballooning, and the postoperative hypertension or cognitive disorders. So, but also could be a disaster and a dramatic complication for the patient. There's some kind of tentative in order to prevent this particular complication using an accurate best deployment of the endograft in the more proximal aspect in the arch, a more parallel shape, but still the complication could appear and could be real difficult to prevent. Is in some kind is unpredictable. So the axial conformability still is there, but we had in the past this kind of phenomenon, collapse and serial coarctations. From also again from the companies, we have some kind of solutions, partial solutions of some kind, in order to have a different kind of deployment, in order to have more conformability and to reach the inner curvature in more elegant and more alien with a nice alignment with the inner curvature. And even we have the opportunity to play with the supraortic trunks with branching devices or the branching techniques or periscopes or another kind of devices. Even the anchors could be also useful in order to perform better conformability in the arch. With the aortic branches on the top and proximal and distal aspect, we have also some kind of solution from the companies, and also for another kind of very intuitive and creative ideas like a periscope or chimneys, and also the branching technique in combination with TIBA, and another kind of specific custom-made devices in order to play with supraortic trunks, even with in situ fenestrations. Much more appealing seems to be the new branched devices coming from the companies. And for the distal aspect, you have also different kind of creative solutions in order to deal with these particular situations related to the supraortic and distal branches. About the TIBA durability, as well as for EVA durability, is still a concern because the aorta is dynamic, and all the pathology in the aorta seems to be also dynamic if the patient lives longer. And so then is disease progression is another concern, and we need to play with different kind of solutions later on from the open or more often with endovascular solutions for that. We know about the motion in the thoracic aorta, and this kind of dislodgement is quite often. We solve the problem with much more overlapping, and also the upcranial migration for the distal aspect is a concern. And most recently, we have a new concern related to the stiffness of the stent graft and some cardiac or cardiovascular death and morbidity, but it's still too early to have any conclusion about that. So the peak wave velocity is an independent risk factor for increasing cardiovascular mortality and mortality, and so we can need to be aware about that. So in summary, despite the awake evidence, TIVR is the preferred method of repair for the semi-thoracic aneurysm. Technical and technological improvements in combination with the clinical experience have contributed to increase the knowledge and safety of TIVR, but many issues and concerns remain to be fixed for the future investigations. Thank you very much for attention.
Thank you for that comprehensive overview. Next speaker is my faculty colleague, Mike Fishbein, cardiothoracic surgeon here at Stanford, who's going to talk about, we've heard earlier today, a lot of discussion about elephant trunks and the role of elephant trunk in the management of thoracic aortic disease. Mike.
Thank you very much. It's a pleasure to be here, and Mike, thanks for including me in this celebration. So I'm going to talk about the current status of elephant trunks. First, I thought I'd start off with a little history. I think all of you know that Borst first described this in this paper in 1983, talking about using the elephant trunk, which is a Dacron graft down the descending aorta for patients who require a two-stage approach for the patient with the so-called mega aorta. Then in the 1990s, Crawford and Svensson came up with this modified technique to improve or make the distal anastomosis easier by invaginating the Dacron graft and then everting it back out after completing the anastomosis. And then finally, what we're hearing a lot about now is the development of the frozen elephant trunk. Cato described this in 1996. This is a paper from Hanover describing this, where it's really combining the two techniques of the elephant trunk and the endovascular stent graft, placing it antegrade down the graft during your initial operation. There are a number of devices available. To the more common ones shown here. The Thoraflex device on the right is used most commonly now in Europe. It's not commercially available in the United States, but it is available through a clinical trial, which we have the privilege of being part of. So I thought what I would do is to show the applicability of the elephant trunk, both conventional as well as the frozen elephant trunk, that I'd show you some cases. So the first case is a patient who had basically a mega aorta or a diffuse aneurysm. This was in a 24-year-old male who we diagnosed with Marfan syndrome. He really showed up to his urgent care clinic with shortness of breath and was treated for a viral illness. He had an x-ray performed which showed what he initially was told was pneumonia, but then they had an enlarged mediastinum. And so a CT scan was performed which showed this here. And so he had about an 8-centimeter root aneurysm. He had severe AI from the root aneurysm, causing LV dysfunction with ejection fraction at 20%. He had a chronic type A dissection, and his arch actually looks pretty small, though it is big, but his descending aorta is 15 centimeters. So we elected to repair this with a two-stage procedure using the elephant trunk. This shows the initial operation. We wanted to do the shortest operation possible because of his ejection fraction, so we did a mechanical composite valve graft and then a total arch with an elephant trunk shown here. In the cartoon, you can see we take this invaginated trunk, do our anastomosis, which is this elephant trunk shown, and then we sew that to the multi-branch graft to replace the arch. This was his initial CT scan after that procedure. You can see the elephant trunk in the descending aorta. We like to mark it to give an option of endovascular approach. But obviously in this individual with Marfan syndrome, a big aorta with no landing zone, and the fact that he was young, we planned to do an open procedure. One thing to point out, which we'll discuss a little bit later, is you can see that this elephant trunk, the conventional elephant trunk, goes into a narrow true lumen, so you have some narrowing there, where if I just to do this case again, I would consider a frozen elephant trunk, which would help expand that narrow true lumen. So the elephant trunk really helps with your second stage procedure. This is showing the thoracoabdominal aneurysm. The diaphragm's divided, so you have your descending, your abdominal components down here. And this really saves time as well as morbidity for the patient. What we would do is go on pump, grab the elephant trunk and clamp it and sew to that, and so that avoids the need for a circ arrest run. It also avoids the need for dissection proximally, so you reduce the chance of injuring the nerves as well as manipulating the arch, ultimately leading to reduced stroke and hopefully paraplegia, since you don't have to clamp the subclavian. So this is shown here. We opened up the aorta. Here was the long elephant trunk that we then quickly clamped and replaced the descending. You have your intercostals reimplanted as well as your visceral vessels. Some key things to think about is the length of your elephant trunk. We like to say that we use about 10 centimeters. You want it long enough so that you can clamp it, but you don't want it too long, or there is the risk, particularly with a frozen elephant trunk, of paraplegia covering too many intercostals. You also want to make sure that the trunk is fully expanded and not kinked, and we do this at the time of the initial operation with TEE guidance. So this was his completion CT scan, and so it was quite dramatic for this individual who came thinking he was going to get some antibiotics and left with his entire aorta replaced. So what about using elephant trunks for acute type A dissections? This is particularly useful in patients who have malperfusion when the primary intimal tear is in the arch or the descending aorta. With a frozen elephant trunk, you can then treat the malperfusion with a one-stage procedure. You also can use this for aortic remodeling to hopefully prevent future surgery, particularly the descending aorta, but again, this is more of a prophylactic approach. So we used this in a 68-year-old gentleman. He had a CABG about 8 years ago. He showed up with chest pain, AI, and CHF, and he had this type A dissection shown here. So we did a root ascending total arch with a conventional elephant trunk, shown here with clips in the true lumen. Here was a follow-up CT scan, and within 6 months he had excellent remodeling of the aorta. You can see the initial imaging on the top row, and on the bottom row you can see that the aorta completely remodeled in the descending aorta. This was recently published in 2016 from the Hanover group, looking at the first 100 patients with the frozen elephant trunk using the Thoraflex device. And they looked at aortic remodeling for type A dissections, breaking down into zones A, where the device is, and B is from the bottom of the stent graft down to the celiac, and then C is the abdominal component. And I'll just point out here in the left-hand side that within 2 years you had 100% or complete remodeling of the descending aorta where the stent graft was deployed, and for acute dissections about 40% in that zone B and only 20% in the abdominal component. But again, this is prophylactic, so we have to ask ourselves, do we want to do this for an acute type A dissection? But it definitely helps with remodeling for future. A lot of frozen elephant trunks that we're doing here is for the chronic residual dissection after a type A dissection, where the aorta becomes aneurysmal over time. The frozen elephant trunk is helpful for a number of reasons. One, it does help expand that narrow true lumen, like I was showing with the patient, the first case. Also, there's the possibility of treating this with a single stage approach if you're focusing on the descending aorta. And if you can't treat it with a one-stage approach, you are setting yourself up for a second stage approach. And I'll show you some examples where we did have patients, despite placing the elephant trunk, they still had a leak from retrograde filling of the false lumen and aneurysmal dilatation. So this was a patient I just did on Friday as a 44-year-old Marfan patient. She had a previous type A dissection that was treated with a mechanical composite valve graft, and she was referred for a 6-centimeter descending aorta. You can see here the previous surgeons put a very short composite valve graft. There was the residual type A dissection here, and then the large descending aorta, and notice the very small true lumen. So again, the frozen elephant trunk in this situation is very helpful so that your elephant trunk isn't sort of squished in that small space. So this is just showing a quick movie. The head is at the top. This is obviously the heart. Here's her old graft, the remainder of the ascending aorta in the arch, and the vessels are in the vessel loops. This is showing the arch vessels up here, the innominate, left carotid, left subclavian. We anastomosed the elephant trunk into the proximal descending aorta, and then once we're done with the anastomosis, we vert the elephant trunk. We then come antegrade with our Stent-Graft. We've done this both by placing a wire down antegrade, but as well as just looking directly down the true lumen and deploying it. And then I tack it to the Dacron graft. I try to use just a 10-centimeter graft again, keeping in mind that the longer grafts do have a higher risk of paraplegia. And so then here's the completed repair. Now, what about the retrograde filling of the false lumen? So these patients do have to be followed very carefully because many of them will need further interventions, whether it's a TVAR or open repair. So this was another 38-year-old Marfan patient, had a valve-sparing root replacement, had a type B dissection with a retro A. He initially was treated conservatively, but then had dilatation of his arch, so we did a total arch and then a frozen elephant trunk. And you can see here in the imaging, he had continual filling retrograde of the false lumen, and his proximal descending aorta continued to increase in size. So we took him to the operating room to a completion open repair. This is a left thoracotomy. You can see the descending aorta that was enlarged here. The aorta becomes smaller towards the diaphragm. We clamped the elephant trunk. You can see a portion of the stent graft inside of the aorta, and then we sewed the Dacron to both the stent graft and aortic wall, and he did well afterwards. Now, you can also do a second stage completion with a TVAR. We selected to do that in this individual. It was an older person, 77-year-old woman. She had bad COPD, and she was quite frail. And so we felt in this individual it was better served to do a TVAR, and so we extended her TVAR graft down towards the diaphragm. So how at Stanford do we decide whether to do second stage TVAR versus open repair? We do favor an open surgical approach first for low or moderate risk individuals, particularly young people, good operative candidates, anyone with a connective tissue disorder, or if or the anatomy is not suitable for an endovascular approach. Whereas we save an endovascular approach for, like this woman, an older age person with COPD, bad LV function, or someone who's very frail. This is a study that Roselli published at Cleveland Clinic looking at this exact question, comparing their second stage procedure, endovascular versus open, and after doing a propensity match analysis found that although the open patients had higher requirement for transfusions as well as length of stay, that there was no difference in operative mortality in these individuals. But importantly, those with an endovascular approach do need multiple re-interventions, and so these have to be followed closely. Finally, the role in type B dissections. We have used this when the tear extends into the arch, particularly when you have no proximal landing zones due to the size. And so this was in a 57-year-old gentleman, hypertension AFib, presented with an uncomplicated type B dissection. We were treating medically. This individual, if you're looking at Dominic Fleischman's risk calculator, had a high risk of needing future surgery. He had a very large primary intimal tear at 25 millimeters near the carotid and subclavian with the dissection ending in the descending, but there was no reentry tears and no intercostals. So he had a very high inflow with very little outflow of the false lumen. So here was the initial CT imaging. You can see that the dissection extended towards the left carotid. His initial scan showed a descending of 5 centimeters, and within 1 month, you can see that the false lumen increased greatly. The descending increased to almost 8 centimeters. And so again, we treated him with a total arch and a frozen elephant trunk. You can see the very large intimal tear here. And here's his completion CT scan, and we were able to treat everything with the one operation. So I'll go ahead and end there, and thank you very much for allowing me to present.
Thanks, Mike. We don't have time for questions right now, but definitely we'll have time at lunch to talk to each of the speakers about their observations and experience in this area. So our final presentation in this group is trauma management of penetrating ulcers, myconic aneurysms. Ali Azizadeh is going to talk to us about this now from Cedars-Sinai in Los Angeles. Ali.
Thank you very much, Ron. It's a pleasure to be here. My task is to update you on the current status of trauma, penetrating aortic ulcer, intramural hematoma, and myconic aneurysms. We've talked a lot about the history today, and I just want to mention that the history of open repair goes back to the early 1950s. And when you look at endovascular repairs, they start in the 80s with Folidose, the 1991 repair of the abdominal aortic aneurysm by Dr. Perotti, the 1992 repair of the thoracic aneurysm by Dr. Dake, and followed by the commercial approval of these devices. So as you can see from this history, open repair is now approaching 65 years old and would be enrolling in Medicare if it was a person. And TVAR is just entering young adulthood. So the best is yet to come, and we're only seeing the beginning. So multiple applications for TVAR. My task is to talk about trauma. And as you know, this is the second most common cause of death after motor vehicle collisions. And we were one of the early adopters of commercial Stengt-Grafts for treating trauma, and we proposed a 4-grade classification system back in 2009, and this was subsequently adopted by the guidelines for the Society for Vascular Surgery. And as you probably know, most intimal tears or grade 1s are treated with medical therapy. Patients with grade 2 through 4 injuries undergo TVAR. We've also started a nonprofit called the Aortic Trauma Foundation with the aim of education and research in the area of traumatic aortic injury. And one of our first initiatives was a survey of multiple different societies who are stakeholders in the management of traumatic aortic injury. And what we found was that there was a lot of controversy in management of intramural hematomas or grade 2s, with half of the respondents preferring medical therapy for treatment of these grade 2 injuries compared with the other half that performed TVAR. So we have we did a retrospective multi-center study that looked at the current status of management of traumatic aortic injury in 2015, and what we found was that there was really no difference between non-operative management versus TVAR for patients with grade 2 injuries. And these were the independent predictors of all-cause and aortic-related mortality among these patients. For all-cause mortality, the injury severity score, non-operative management, the grade of injury, the Glasgow Coma score all play a role. And for aortic-related mortality specifically, the injury severity score, the grade, and TVAR played a role. So we've initiated this study of non-operative treatment, which is currently being described in the literature specifically for grade 2 injuries. And we looked at this in our own series in Houston, where I came from, and we found that in patients who undergo medical therapy, most of these injuries heal by 6 weeks. There is a difference between grade 1 and grade 2 injuries in terms of the time to heal, but a lot of these grade 2 injuries heal on follow-up imaging. So we have an international multi-center prospective registry sponsored by the Aortic Trauma Foundation to specifically look at the outcome of these patients. And there's currently 14 centers participating. This covers most of the United States, and we're also expanding this to Europe and the rest of the world. So this is currently in progress. And it appears that TEVAR has made a significant difference in the outcome of these patients. This is the national trends in the outcomes of TEVAR for trauma. As you can see, the incidence of TEVAR has gone from 1% to almost 40% over the course of this study timeline, and open repair has reduced from 19% down to 6%. This has translated into a benefit for patients. This is the in-hospital mortality by treatment strategy. You can see that the mortality for all traumatic aortic injury admissions, shown here in blue, has reduced. Same has happened for mortality of TEVAR and any intervention in patients with traumatic aortic injury. Switching gears now, talking about penetrating aortic ulcer and intramural hematomas. As you know, this is part of the spectrum of aortic dissection with similarities between the two pathologies. This is a often difficult to understand and very controversial pathology. This is one of the larger series coming out of Michigan, 95 patients. 37 had open repair, 58 had TEVAR. They intervened for rupture, saccular aneurysm, or symptoms with a mortality rate of close to 10%. Early adverse events were predicted by rupture, total descending repair, and open repair. And for late mortality, age, urgent presentation were predictors, and the type of repair was not. So some take-home points is that there was no difference in the outcome of open versus endovascular repair in this group, and at the follow-up time, almost half the patients were dead by 10 years. So looking at the outcomes, it appeared that patients, the penetrating aortic ulcer patients who had an associated intramural hematoma did worse compared to those who just had penetrating aortic ulcers. This is a consensus statement that comes out of Europe. They looked at 46 studies totaling close to 1,400 patients. About 925 had intramural hematomas. The 30-day mortality was 3.9%. The 3-year aortic-related mortality for medical therapy was 5.4%. Those who had open repair, 23.2%, and endovascular repair, 7.1%. Looking at the subgroup that had penetrating aortic ulcers, the mortality rates were higher. The 30-day for open repair was close to 16% compared to only 7.2% for those who underwent TEVAR. Some of the high-risk features from this study: age over 70, initial aortic diameter over 45, mean aortic growth rate over 5 millimeters a year, wall thickness over 10 millimeters, pleural fusion, aortic ulcer, and ulcer-like projections were high-risk features for intramural hematomas. And looking at penetrating aortic ulcers, patients who had symptoms despite medical therapy, those who had pleural fusion or associated intramural hematoma had these high-risk features. In addition, initial penetrating aortic ulcer depth over 10 millimeters and diameter over 20 millimeters were also risk factors. So according to the consensus statement, surgical endovascular treatment for complications is indicated for patients who had hemodynamic instability, persistence pain, signs of impending rupture, or progressive periaortic hemorrhage in 2 successive imaging studies. As far as mycotic aneurysms are concerned, TEVAR really serves as a bridge to open repair. As you can see in this patient who came in with a ruptured mycotic aneurysm, we performed TEVAR followed by subsequent explantation and conversion to open repair at 4 months with wrapping of the aorta with a lat dorsi flap. So, summary of the current status for traumatic aortic injury. TEVAR is the treatment of choice for patients with grade 2 through 4. Medical therapy is accepted for grade 1 and selected patients with grade 2 injuries. With regards to penetrating aortic ulcer and intramural hematoma, TEVAR is preferred over open repair for selected patients with very acceptable results. And as far as mycotic aneurysms, this TEVAR serves as a bridge to open repair. So I want to congratulate Dr. Dake, Stanford, and the rest of the faculty here on the 25th anniversary of the first TEVAR, and thank you very much for your attention.
Thank you, Ali, for a very clear presentation and being the first speaker of the day who finished in less than 10 minutes. Now we move to the current status of dissection, starting with the acute complicated dissection with Dietmar Bockler from Germany.
Dear Mr. Chairman, ladies and gentlemen, friends and colleagues, before we kick off the next chapter on dissections, I would like to really thank Mike for inviting me and for being part of this distinguished faculty, and congratulations to this excellent day. So, ladies and gentlemen, if we talk about aortic dissections, it's a complex disease within an entity called acute aortic syndrome, together with penetrating aortic ulcers, intramural hematoma, and aneurysms. And the difference is based on the pathophysiology of the wall. So if you look at dissection, it's in the media with the underlying cystic medial necrosis, as you can see here on these figures and histological findings. And you all agree that this disease is really challenging, fascinating, and sometimes difficult to understand regarding extension, hemodynamics, and morphology. So let's step back 47 years because we are in Stanford. 47 years ago, the Stanford classification, one of the milestones in the treatment of aortic dissection, has been developed. And you will not believe it, it was based on this paper by Pat Daly, who really differentiated between medical and operative surgery, dividing type A and type B. And it was only 35 patients being the base of what we do today. It's because Stanford classification is still in clinical use in everyday practice. So 12 type B dissections in total have been analyzed. But since then, the practice totally changed. I think everybody agrees open surgery is abandoned and the shift was towards best medical treatment and endovascular first and only. And there's increasing evidence on that. But let's go back again, another milestone. Mike Dake doing the first thoracic aortic stent graft in thoracic aortic disease, which was another milestone which really helped a lot of patients being treated for dissections today. So what we're going to face is 25 to 30% out of all dissection patients having a Stanford B dissection. And the question is now how to treat them. And I will cover the acute complicated with rupture, malperfusion, uncontrolled pain, hypertension, and Christoph and Mark will do acute, uncomplicated, and chronic. So there's plenty evidence, and Greg Miller showed some of them on the outcome of acute type B dissection. And in this series, the mortality of complicated dissection was 17% compared to 1.2 in uncomplicated and late interventions of 7.6. And I'm sure you all know and everybody's aware of the evidence provided by the IRID registry, and I just show you this picture, again underlying the need for treatment in patients with complicated type B dissection, 20% mortality. Overall, it's 12.4%, but 20% in complicated versus 6.1, highly significant in uncomplicated. And again, no big miracle, TEVAR does much better than open surgery. So that's why we treat those patients with stent grafting. And we can show this benefit over time. And you see surgical management doesn't play any role anymore. And endovascular management after 60 days does even better with best medical treatment alone. And I have this slide from Christoph showing that it's not only the treatment you choose, but also the patient selection and the comorbidities. If you have no risk factors, they do much better than if they come with shock, hypotension, and a lot of cardiovascular comorbidities. So we have to be aware which patient we're going to treat and how to select. And this is underlined by a recent meta-analysis showing really that TIVA is doing much better than open. This is no wonder, but 7.3% 30-day mortality, a lower stroke rate, and a lower spinal cord ischemia rate compared to open surgery. And this was the base evidence which came into all the guidelines and consensus documents you know of, even the last published European guideline being presented by Vincent Rambau today. So everybody really agreed without any randomized trial that endovascular treatment is the first-line treatment for acute complicated dissection. And the treatment goals are very easily to understand. You want to close the entry tier, the main entry tier and the top distal arch, to really remodel the true lumen compression, to reperfuse your organs. And on the other side, you want to really induce false lumen thrombosis to prevent rupture and late and aortic expansion and late rupture. So these are the treatment goals, and normally you take a 20 centimeter single device to really cover the primary entry, to decompress your true lumen and to induce false lumen thrombosis in order to get aortic remodeling as soon as possible. The only indication for a long segment stent graft, like in this case, is of course contained or free rupture of the false lumen. If you ask and look for the literature for the ideal stent graft, there's no consensus and no studies out there. I'm sure every one of us has some preferences. It's about conformability, it's about radial force and the underlying pathology, and of course profile. All these are influencing factors of your device selection. But we have consensus that you should not balloon, you should avoid bare stenting, and I think some of the issues have been mentioned by Vincent as well, because we're treating patients with really fragile aortic wall conditions. If you don't want to increase the risk of paraplegia, Christoph Nienaber really promoted the petticoat concept of professional extension to induce complete attachment. You can get and induce a better remodeling of your aorta without overstenting intercostals in order to reduce the paraplegia rate. Stable trial, you all are aware of that, is showing quite a good evidence that works, and this is just an example from Melisano, who published his series and experience, how it can work by extending your stent graft with a bare stent and induce remodeling. We also know that especially in acute dissections, the influence of endovascular experience is significant. If you have less experience than 20 patients, either per center or per surgeon or interventionalist, you have less good results. So it's a significant importance to have a high volume and good experience. Coming back to indications, I think this is clear that a patient coming with a rupture, this is 2 weeks ago, needs treatment immediately with a stent grafting down to the celiac trunk, and we did a picture here after thoracoscopy and taking the hematoma out, and you can see the rupture site of the false lumen close to the distal arch. Malperfusion, and you see this patient, a musician coming in 8 weeks ago with a big tear, high pressure in the false lumen, pleural effusion, and a lack of the right renal and the true lumen compression down here. Very easily to see, and this patient went into the OR, got his first stent graft. You see here the initial angiography. We tried to save some contrast because of renal insufficiency, and the patient got a carotid subclavian bypass, his first stent graft. But what happened after the first stent graft, that the malperfusion at the abdominal segment still maintained. So we did not apply the petticoat, but used a second stent graft. And with this second stent graft, the true lumen decompressed and opened easily, and we did additionally a renal stenting. So malperfusion is a very important indication, and it's sometimes not easy to really differentiate between static and dynamic occlusion. So it's very important to understand the pathology and the dissecting flap mechanics and hemodynamics behind that events. Last but not least, uncontrolled pain and hypertension. A 29, very young and very healthy lady came in with a combination of intramural hematoma and dissection, and she was not treatable with painkillers and antihypertensive medication. So we brought her into the OR. We saved the subclavian because we knew that we're going to really have to stent graft the whole descending aorta. And this is the result here after 4 years. She's doing well after all that time. So last but not least, it's a balance between benefit and risk if you treat these acute complicated patients. I think that has been highlighted by Vincente, so I will go over that very quickly. Retrograde dissection, very, very important. In this subgroup of patients with fragile anatomy, you see we have to take care of less radial force and less oversizing compared to degenerative disease. We have this phenomenon of stent graft-induced new entries, an incidence of 3.2%, much higher in connective tissue disease with a high associated mortality. Stroke is an issue not so much because of burden in dissection, but arch morphology, and we find out that especially in dissection type 3 it's very frequently observed, so these are at higher risk for stroke. Paraplegia is an important issue mentioned before because of the collateral network, so maybe this is really out of IFU and not according to the consensus treatment of the last 10 years. Spot stent grafting in single distal entries may be a solution to reduce that. Mike and your colleagues, you really contributed with another milestone to really help physician perspective for decision making in daily practice. There you see that this is very important to really help to find the right solution in this emergency setting. So in summary, ladies and gentlemen, aortic type dissection is fascinating but also challenging. TIVA is first-line treatment in those patients with complicated type B dissection. The technology and the concept is evolving towards uncomplicated, Christoph will talk about that, and even maybe type A dissections. So physicians, and that's something I would like to highlight at Stanford, really contributed for more than 40 years to a better understanding of aortic dissections. These are the highlights and milestones from Stanford. Thank you for doing this work. Congratulations for your 25th anniversary for the first stent graft implant. And Mike, thank you very much for a long ongoing friendship. Thank you very much.
Thank you, Dietmar. Now we invite Chris Nienaber to present on acute uncomplicated, slightly more controversial.
Only slightly more. Thank you again. Thank you very much for the introduction. Thank you, Dietmar, for setting this up. And thank you, Mike, for having me here. Before we actually get ready to present, I missed the break, actually, or we basically skipped the break when I wanted to upload my talk. So we have to spend a moment here, but I use that moment to, again, thank you for the friendship. And I remember it's now 18 years ago when we met first on the occasion of a meeting in Hamburg at the time on the heels of the two publications addressing stent grafting of type B dissection. We coined it Advances in Understanding Aortic Disease in 1999. And I had only some very few photographs that are not worth showing here, but we all remember very vividly. Craig was there, Scott was there. We actually chauffeured you from the airport. My assistant drove you to the hotel, and we started there in the era before digitalization took effect. And we were all showing slides and things like that. They were hard to retrieve, so I just remember this day in September 1999 very vividly, because we basically came together to celebrate the two publications that basically changed a little bit the approach to dissection. Let me just start here. When you sent this invitation to me, Michael, I was a little bit tempted because you're always so precise, and I thought myself, he calls it acute uncomplicated aortic dissection. He doesn't tell me to talk about type B dissection. So again, do you want to test me on the type A's as well, or should I bring that in? Again, so I added my ideas or my thoughts to this title or suggested title, and I will very briefly just elaborate on that aspect and that avenue as well. There's no talk on dissection without this introduction on George II in 1760, who actually was the first really scientifically bold and sound description of a type A dissection that led to immediate death or in a short period of time due to pericardial effusion. But we all know that, we deal with that every day. But let's fast forward into the next decade, actually. What you see here is what's happening to us here in the US and in Europe in the next couple of years. And it's a projection from Japan. You know that the demographics in Japan basically precede our demographic evolution by 10 to 15 years, I was told by some statisticians. And what you see here in red is the increasing load, patient load and case load of aortic condition that we have to deal with. At the same time, also in yellow, valvular issues are on the rise. However, in green, coronary disease and coronary interventions are going to settle and probably actually taper down a little bit. This is in the next couple of years happening here as well. And we know already from Sweden, from statistics in Sweden, that operations and intervention to thoracic aneurysm and dissection will also be up in both men and women. We're still using this classification system, and Dietmar, you were so smart to talk about the Stanford contribution and everything that has been developed here on the basis of 12 patients. But I'm wondering, and similar to Mike, whether this is still useful today, and I'm pondering back and forth. I'm not sure whether we should actually repeal or replace all that, or whether it's worthwhile to be a little bit more smart and think about the historic invention to actually have that system, because it's still helpful today. But what we see at the same time, still dealing with those Stanford and DeBakey classifications, that I think it's not the time to repeal and replace them. I think it is different now. Dissect is a good contribution, but actually, if you read Dissect between the lines, it basically tells you that essentially nobody is at no risk with a dissection. So we're moving towards a personalized management of type B dissection, clearly. And I think with the approach, or with the attempt to avoid thoracotomies, there's a lot of creative solutions in the near future to tackle patients with type B dissection, type A dissection, arch problems. And a few sketches here show you the potential. It's only the only thing that I wanted to mention here. And I almost stopped with a little excursion to the proximal part of the aorta here. Classic treatment of type A dissection certainly is a classic surgical domain with various opportunities. But some of these type A dissections, even without surgery, survive up to 60 days or even longer. And they may be not well on medical management for a long time, and there may actually some options for endovascular treatment in these particular patients as well. And here's an example, a recent example from our hospital. Last October, a young guy, 54, was operated at night for a type A dissection. It turned out that, as you see on the left lower side, that there was a residual, relatively big entity close to the arch, and the patient didn't, for no reason, accept a second thoracotomy, and he wasn't actually in a good shape to tolerate that. And we decided, together with my partners in cardiac surgery, to subject the patient to a stent-graft intervention with a small Cook device placed across his lesion, distal to the suture line of the napkin ring intervention. And we did some additional work to the left and right renal artery because they were compromised as well from pressure in the false lumen. So it just shows you the potential of future interventions to the ascending aorta. But my task is to talk about a type B dissection, of course. And here is my first case, the first case that I did successfully, I have to say, and which was the first patient in the before mentioned publication in 1999, together with Michael's publication. They both appeared in the, I think, May issue of the New England Journal, 20th of May, back to back. And it's very remarkable what you see here is authors from 3 or 4 different disciplines working together and being co-authors on this paper. It's multinational, multidisciplinary, Italy and Germany, multidisciplinary radiology, vascular surgery, cardiac surgery, and 2 cardiologists involved in it, so very modern, and only 24 patients. 12 of them were subjected to stent graft and 12 to open surgery, which was still the standard at the time. The result and the upshot of both papers, the Stanford paper with Mike as the lead author, and our collaborative effort of 24 and total 19 patients here from Stanford and Japan, showed that the concept is feasible, safe, patients enjoy a quick recovery, and from there on, there was a big question mark for open surgery in this regard. Here's Michael's publication with a similar trend and a similar conclusion. And here's a case. And what you see here is a very rough stent graft procedure, but it did the job. It looks very stiff and not conformable. It was a really very primitive first generation talon stent, 15 centimeters long, but it did the job. It was sitting there almost like a steep angle in the arch, moving this arch to a Gothic arch, but redirecting the flow to the true lumen. And this patient, actually saw him 2 weeks ago, is still alive. He is awaiting a double valve repair now, a second surgical intervention to his aortic and a first surgical replacement of his mitral valve coming up later this month. But his aorta is still stable and he didn't expand his false lumen. We have seen this before. It shows you that we're moving to a different classification system besides the individualized approach that we are going to look for in the next couple of years. And it shows you that endovascular management in this composite of patients, more than 600 patients from IRAD, both complicated and uncomplicated ones, show that endovascular management may actually stabilize on long term the outcome of these patients. In addition to medical management, all these patients that get endovascular management need medical management as well. They're all well controlled and looked after by cardiologists or hypertensive experts. Again, IRAD has been mentioned. I think IRAD is a source of controversial data. You can love it or hate it, but it is some source of data that can be a discussion or spur the discussion for trials and basically open up the eyes for new questions. We identified in 2006 high and low risk patients. The high risk patients are shown on the lower side of this family of curves, and it shows basically the outcome of patients with so-called complicated features of diabetes dissection, malperfusion, or imminent rupture. Usual treatment, and we discussed that before, and Dietmar has shown that very elegantly, is TEVAR with a petticoat in addition to it, or just a plain TEVAR. There are studies supporting the outcome, no randomized studies, just observational evidence, but it's enough to grant it a one recommendation. This image is nice to show for your junior friends in the back. It shows you not only the immediate resolution of the problem with abolishment of malperfusion on the left-hand side, but also the trigger point for remodeling. The endovascular solution for this patient not only helped to save the day due to the malperfusion on the left-hand side, but also initiated remodeling, as you can see, from left to right, from immediately after in the center to a year later with almost completely remodeled distal aorta. There's data, there's only one, the so-called stable trial that I'm going to show here, to show you this outcome in a stable long-term expectation with no immediately increasing mortality, but rather a stable long-term course, which granted this indication a so-called 1C recommendation by the European Society of Cardiology guideline published in 2014, and is basically not much different from the recently mentioned cardiovascular guidelines mentioned by Vincente. What to do with the low-risk patients, the patients that are considered to be stable, uncomplicated, clinically completely off any kind of pain syndromes. You can send them home after a couple of weeks, usually, or 2 weeks, and you keep them under surveillance if you have a surveillance program, or they're basically lost over time. In IRAD, we found out that after 5 years, you have to consider a 40 to 42% mortality. Exactly the same figure has been previously published in the vascular surgery, Annals of Vascular Surgery in 2007, 42% mortality, 5 years. That was the background for the INSTEAD trial that showed no difference up to 2 years, but a crossover rate of 14%. INSTEAD was just a little bit disappointed and underpowered and prompted us to follow these patients, the surviving patients, longer, up to 5 to 7 years. And again, this signal of a stable long-term course emerged in red as compared to blue under medical management only, and showed there must be something in a stabilization early on, an investment into a longer stable period with a stent graft, a scaffold, even in a patient considered to be uncomplicated. These data were supported basically simultaneously by registry data from IRAD, by the ADSORB trial. The ADSORB trial in uncomplicated acute dissection hasn't been mentioned before, no difference between the two treatment options, and by a large Chinese registry now with 7 years follow-up with an edge for preemptive stenting. So the data on aggregate on 1 or 2 randomized studies and 2 or 3 registry now is consistent and basically reflect a very strong signal. This is an interesting picture that I found, Michel, recently. You remember that probably, on the Côte d'Azur in Marseille in 2011, I think, or 2012, I don't remember. We were thinking of the need for another randomized trial. I was talking about the long-term INSTA trial at the meeting, and we were basically over a cup of coffee and later a couple of glasses of wine deciding and sketching up another trial, a randomized trial, to look at the so-called uncomplicated one. The trial so far didn't materialize, probably because we are too much into drinking or celebrating, and you had a smoke with Rosella, one of the early adopters as well, that worked very closely with me on the project, and Michael knows her very well as well, on that particular meeting in France. Time flew, and we realized that there is a critical observation that stabilizes these patients, which is basically full false lumen thrombosis. And that has independently been consolidated and repeated and corroborated in Japan, in the IRAT database, with a odds ratio of more than 5. So with a stabilized and thrombosed false lumen, you have a great chance to stabilize your outcome. Based on these insights, even for the so-called uncomplicated type B dissection, which nobody really can define properly, the European Society of Cardiology granted a 2A level of evidence B recommendation because there was a little bit of randomized data, although underpowered. I tried to find an analogy for an uncomplicated type B dissection. And I was invited a couple of years ago to a lecture in South Africa, and I was invited to a safari, and I found these pictures. You know, we had actually a camp out, or sort of camping in the savannah there, and this is a picture taken from the campground, and this cheetah there was behind, as you see, behind a fence, so that the camping was basically considered to be safe. But I turned around, and there was another one, not behind a fence, and you see that here, this cat in the front was just next to the table, and we didn't realize it. And that's probably a good analogy for an uncomplicated type B dissection. You don't realize the problem, but the problem is there. It's not under a fence. We know the high-risk group. And this has been mentioned before, the work of Dr. Kato in Japan. Early expansion, false lumen beyond 22 millimeters, is a strong predictor. Arturo Evangelista, again, another cardiologist who did some important groundwork in this area, he found that the big entry tear is probably a correlate to a big false lumen, or an expanded false lumen. And patients with a 10 millimeter or more entry tear are candidates for problems, and they should be treated either surgically or with a stent graft. Clinically, hypertension and repetitive pain or refractory pain are very important clinical signs to look at, and if they cannot be treated adequately, the patient should be undergoing some consideration for endovascular or open repair. Another thing is aortic inflammation. We are now in an era where we can subject the patient to PET CT scanning, and this is a case, one of a series of over 50 now, of a chronic type B stable case with enhanced uptake of FDG around the partially thrombosed false lumen. As you can see, he was stented because of that evidence of inflammation and because of biological markers in the serum. The D dimers were up, the platelet counts was down, and with the pacification intervention using this stent graft, biology went back to normal, and the enhanced uptake of FDG also normalized. If you don't do anything for these patients on long term and you leave them on drugs, you end up after 3 years, in most cases, with an expansion of the false lumen, like in this case, up to 6 centimeters. Difficult to treat. You have to send them to Eric Verhoeven for complicated intervention. But this can be avoided, I think. And we are working now in hybrid theaters. The technology since INSTAT has improved a couple of iterations, and we have learned from our early mistakes, and we have a safer area around us, a safer environment to work in. A new generation is coming up working with me to really express a big interest in working with these pathologies. Our referral system has changed. The ambulance, first ambulance in the US is, of course, completely different. Now we have referring system, network services, data and images are fed in. We can prepare for an emergency intervention while the patient is on transportation. And this is just one example of how it could be installed in various referral networks. And the decision-making process in my new environment in London is also much more complex. I mean, we're working very closely together with vascular surgeons. You may know a couple of them cardiac surgeons and imaging specialists and cardiologists, in order to offer the patient the option that we can offer today. And one of them is, in a safe environment, a preemptive intervention in type B dissection. And this group here that you can see here is not only making decisions based on their own insights and images, but also on the heels of experts. One of them is here, that have basically said very early on that that agreed upon the fact that the aorta should be just one channel. Thank you very much for your attention.
Thank you, Chris, for this excellent update on the status of acute uncomplicated repair. Next, we go to the chronic dissection, and Mark Farber will update us on the current status of TEVAR for chronic dissection.
Thanks, Mac, and thanks, Mike, for inviting me to this wonderful symposium. Now, as you've heard from the previous speakers, our knowledge and terminology changed somewhat early on. We really thought that chronic dissections were anything beyond 2 weeks. But for most of us now, the chronic classification really defines those patients beyond 30 days, and in some classifications begins at somewhere between 2 and 3 months. Now, your current options for managing patients endovascularly with chronic type B aortic dissections includes TEVAR alone, TEVAR with false lumen exclusion techniques, TEVAR with distal extension, namely bare stenting, which is really more for the acute patients, or with branched and fenestrated repair, as Christoph recently mentioned. Now in the U.S., we have only 2 grafts approved for use for dissection cases, currently the Gore CTAG and the Medtronic Valiant device. Now, I should mention that TEVAR for type 3A dissections is probably a little unique. You know, these patients, the segment is isolated obviously to the thoracic aorta, does not extend to the visceral segment, but in our clinical experience, these patients generally present acutely. They don't have outflow fenestrations. That means that the false lumen pressurization is much higher, and generally they're managed in the acute phase. And rarely do these come to see us in the chronic phase, but you may occasionally see one. So for type 3As, I think that's where TEVAR alone may be beneficial in the treatment, but as I mentioned, mainly in the acute treatment phase. Now, when you look at outcomes for TEVAR for complicated chronic type B dissections, you have to really look at modeling versus no remodeling. As Christoph said, those patients with persistent false lumen perfusion leads to lack of remodeling, and those patients that have a lack of remodeling have a higher incidence of mortality. And in this study by Manny, a third of the patients had no remodeling, and you can see that's going to result in poor outcomes. Now, what about the predictors of aneurysmal change? Song and his colleagues really looked at this in 51 patients with type A and about the same number of type B dissections. And you see there the aneurysmal degeneration happened in the arch, the upper and the mid descending aorta, as well as the lower and the abdominal. But if you look at the numbers, about 72% of them were in the upper and mid portions of the thoracic aorta. And their main finding was that a false lumen dilatation greater than 22 millimeters was a good predictor that this was going to occur. Now, if we can include the false lumen, there may be benefits to the long-term aspect. Thilo and his colleagues really have been some of the recent pioneers of this, using either coils, glue. Techniques such as candy plug or Knickerbocker are now employed when you have access to those type of devices. Now, Thiel's had 3 publications, but generally over the 3-year period, he's treated about 33 patients, a little more than half with the candy plug technique and the other 15 with the Knickerbocker technique. And he was successful in nearly all of those patients, inducing some false lumen thrombosis. His 30-day mortality in this cohort was 0%, and no patients experienced spinal cord ischemia. His false lumen thrombosis for the candy plug was 100%, but for the Knickerbocker was only 73%. But with re-intervention, he was able to completely thrombose those additional patients with those techniques. Now, you can use alternative techniques, as Christoph said. You can do fenestrated and branched devices. Really, what's changed is our use of preloaded catheters and wires. It allows us to keep the device, as you see here, in a constrained position. The sheath is covering the distal aspect of the device. We can bring the wire from the arm and get out into the visceral vessels, even when it's a small flow lumen. It's actually rather easy because the wire has nowhere to go except into the branch vessel because there's not much space there for it to go into like you do in large aneurysm sacs. By doing that, we can maintain the delivery system and maximize our use of the space. But I think you can't do it alone. You need other additional components. We have a good use of fenestrated limbs. Fortunately, the iliacs are not that dilated, and positioning a fenestration without actually stenting it can be very successful in maintaining hypogastric perfusion. Here you see the patient's right hypogastric. Most of the tears are always on the outer side away from the hypogastric, so positioning your fenestration in this location allows you to thrombose that reentry tear at the bottom and still maintain hypogastric perfusion, which is critical for these patients from a spinal cord ischemic perspective. So I took a look at our IDE, and about 7% of our patients, 13, have undergone FEVAR or BVAR for type B chronic dissections. Our mean age in this group is about 60. Most of them are males. We've been able to do custom manufactured devices, about 92%, and off-the-shelf devices, T-branch, in about 8%. You see the procedure time there on the average of 237 minutes and a low contrast use. Our mortality is only 7.7%. One patient died of a PEA arrest on day 2. One temporary paraplegia, which resolved, and our branch vessel patency is 100%. I think part of that low paraplegia risk and patency is due to the fact that we stage these procedures. You see that the majority of them are type 2, but about 40% are staged, and I think that's a big benefit. We have had 2 type significant endoleaks, 1C and a 3, which are both resolved with secondary interventions. And overall, late mortality is only 8%. Now, this is Piotr Kasparek's data, which is similar. It's probably the largest publication I found recently of 31 patients. You see their type 2 endoleaks are not insignificant, and 6 of his patients, and type 1B and 6. Overall mortality about 10%, but a very good false lumen thrombosis rate at 88%. So I'd say the current strategy for chronic type B dissections probably looks something like this. TVAR down to somewhere near the celiac artery. Some people take it all the way to the celiac artery to induce as much thrombosis as you can. You should consider false lumen thrombotic techniques such as candy plug or Knickerbocker or coiling, depends on what you have access to. And you need to really monitor the infrarenal and visceral segment for continued connections and enlargement. Those, when they occur, can be managed with branched or fenestrated devices, as well as techniques, as I showed you with the fenestrated limb, to exclude those other secondary entry tears, or both in those cases. So overall, current management strategies for complicated type B dissections in flux. TVAR alone is unlikely to be a durable strategy for most except type 3 type B dissections. And fenestrated and branched repairs with or without false lumen thrombosis strategies are currently being employed with good short-term success, but we don't have any mid or long-term data yet. And as device options become more readily available, complex, complete exclusion of false lumen become more routine across the world. Thank you.
Last speaker before lunch is Dr. Krasher, the other token cardiologist of the program. He will discuss the current status of percutaneous EVAR.
So I'm going to talk about the use of a large bore closure during EVAR, TVAR, and other procedures that require those. Here are my disclosures. So we know that surgical access and surgical femoral artery repair for EVAR is well-established, well-accepted technique for the last 27 years. But there are obviously certain disadvantages, particularly in certain scenarios, such as using general anesthesia in the patients that have serious comorbid conditions. It can be time-consuming, particularly with morbidly obese patients. Also, it's painful to a certain degree, and also there is a higher risk of infection in a certain subset of patients. So percutaneous large bore vascular closure has evolved to prevent the risk of surgery, particularly in patients with serious comorbid conditions. And so far here in the United States, we have 2 devices that are used to a large scale for closure of the access sites. One is ProStar XL that was introduced in 1996 here in the United States, and the other one is ProGlide that was introduced in 2014. We're all familiar with those devices. ProStar is a little bit obviously older device. Typically, you use one device for the closure of the access site of all the way up to 24 French. It is approved in Europe for large bore closure all the way to up to 24 French device. But there are certain disadvantages of this device. There is a significantly prolonged curve to learn how to use the device. It has its certain idiosyncrasies. It is not very extensively used, and it fails in 5 to 20% of patients, obviously depending on your level of expertise and your patient selection. ProGlide is an approved device in the United States for closure all the way up to 21 French access sites. It has a significantly shorter learning curve. It is very frequently used for diagnostic and many interventional procedures. But it also has certain disadvantages that for large bore closure, you have to use at least 2 devices. And when you talk about 24 French, you probably have to use 3 devices, maybe up to 20% of instances, and it can fail in 5 to 20% of cases. So you all are familiar to the best practice how to gain access. Typically, we use micropuncture and ultrasound guidance for the best approach. One ProStar is used for all those sizes up to 24, and at least 2 ProGlides for large bore access sites. Then you deploy your endograft of choice, and for ProStar you have to form a knot, sliding knot or a clinch knot, and for ProGlide you have a dummy-proof preformed sliding knot, and at the end you pull on your rail, either of ProStar or ProGlide, over the wire, and hopefully you'll have a good hemostasis. And it's a very small incision, usually about 5 or 6 millimeters, and one Steri-strip is sufficient to cover the access site. So when did and where did the PVAR started? To the best of my recollection, I'm not sure whether it was done anywhere else. We did it for the first time on June 4th, 1996 at Texas Heart Institute. You can see me introducing a 14 French sheath. This was done in local anesthesia and via percutaneous approach using my mentor, Dr. Cooley's approach, modify, simplify, and apply technique. And we used either 12 French sheets or 14 French sheets at that time. And you can see the angiogram pre and the angiogram post procedure. Dr. Ted Dietrich was with me when we did the first live transmission in September of 1997 of the first PVAR procedure. And I was teaching how to do suturing the polyester, actually PTFE material to the stent with 6-0-Prolene sutures. And we published, and other ones have published the technique with ProGlide and ProStar in pre-close fashion on numerous occasions. And last year we celebrated 20th anniversary of the first PVAR that we performed at our institution. From the very beginning, our idea was to reduce the risk of the procedure, or reduce mortality and morbidity of the procedure, and also reduce the cost of the procedure. So we started doing procedures in the cardiac cath lab under percutaneous approach and local anesthesia, and we actually implemented from the very beginning so-called fast-track protocol, which means discharging the patients next day after the procedure. And here are some of our results. Over 2,200 procedures were performed using that approach. The great majority were done percutaneously under local anesthesia and fast-track protocol. The closure success, either with ProStar and ProGlide, was pretty high, 97 to 96%. Very low incidence of complications, hospital mortality of 0.3% for all comers, and the access site infection rate of 1%. So obviously, and this has been shown from many other institutions, single center reports, that this technique works, but it was not validated in a true sense and accepted in a broader range until a so-called prospective multi-center randomized trial of a percutaneous EVAR, which was coin-labeled as a PVAR trial that was carried on in the United States. And ProGlide was used, ProStar was used as well. The ProGlide technical success rate was 94%. And what it also, this trial revealed that the incidence of vascular complications at 30-day of follow-up was lower with the use of a ProGlide rather than with surgical access and repair. But in addition to that, there were other benefits. The procedure was shorter, and the time to hemostasis was shorter. There was also less need for blood transfusion. And there were several publications that we published related to the PVAR trial, but there were certain problems and maybe issues related to the PVAR trial data. Number one, we really didn't answer the question whether PVAR and local anesthesia offers lower mortality and morbidity than CVAR and general anesthesia for all comers. And the secondary analysis were only observational and would require a larger number of patients in another study. And also in this trial, the device that was used was 21 French OD. A lot of things have changed, and the devices are becoming smaller and smaller, and currently we have 14 French OD device available. So this kind of initiated another trial, which was so-called least invasive fast-track EVAR or LIFE registry that we partially participated in organizing, with the primary objective was clinical and cost benefits associated with the use of 14 French ovation Stanford under what we call a fast-track protocol that we have been practicing at our institution for over 20 years, which means no general anesthesia, no ICU admission, next day discharge, and obviously percutaneous access and percutaneous femoral artery repair. So again, ProGlide was used, and ProGlide success rate was 97%, very close to what we have shown in our personal observations. But we also found with this trial that as far as the incidence of major adverse events was the lowest ever reported with any EVAR trial anywhere of 0.4% at 1 month of follow-up. In addition to that, in comparison with other data that's available in the fast-track protocol, the procedure was significantly shorter using this approach. The hospital stay was shorter, and obviously by design of the protocol, no admission to ICU were required. And here is a preliminary publication of this data. So what is on horizon as far as closure is concerned? Well, ProStar works well for certain people. ProGlide also works very well, but those devices have to be used in a pre-closed fashion. They are now the dedicated devices for large bore closure. So there are newer devices you can see here that are on the horizon. Most of them are already approved in Europe, and only one, Essential Medical Manta, is currently undergoing clinical trial here in the United States. So for us here in the United States, probably this is going to be the first one that will be a dedicated device and approved for closure of the large bore access sites. There are two sizes, 14 and 18 French. It's very similar to AngioSeal, except it's larger. I call it AngioSeal on steroids. And the data from the European trial, and here you can see the device by Nick Van Meegem, works very well for large bore closure, even in a patient that is fully anticoagulated. And again, this is the device that's delivered over the wire, post-procedure, okay, so which is different than with the other devices that are currently being used here in the United States. Here are the results. It primarily was used for the TAVR procedures. The success rate was 94% as far as achieving hemostasis within 10 minutes, and median time to hemostasis was 23 seconds, only 2% incidence of vascular complications. And as I mentioned, there's a trial ongoing here in the United States in 19 sites. Over 200 patients have been already enrolled in the clinical trial. We need over 300 patients to complete the trial. So in conclusion, there is ample evidence from single center studies and also from a PVAR and LIFE trial that PVAR offers significant benefits in comparison to CVAR. In the next decade, we will see increasing use of large bore vascular closure devices due to increasing popularity of the percutaneous approach for EVAR, TEVAR, and TAVR. ProGlide has been validated as a useful device during PVAR procedures, all the way up to 21 French OD devices. And several dedicated large bore vascular closure devices are emerging, and they're already available in Europe. Some of them are bioabsorbable. All of them are over-the-wire devices, and they are deployed post-intervention. So, in summary, to complete my presentation, I would like to mention Sir Isaac Newton's statement, "If I have seen further, it is by standing on the shoulders of the giants." And here are some of my giants, and most of them are here in the audience. Thank you very much for your attention.
Thank you very much, Zvonko. This was amazing. And now you're allowed to eat. We will resume in 15 minutes.
Okay, so good afternoon, everyone. Welcome to the working lunch session. I see most people are still eating. So first up, Ron, got to cut through the noise. Yep. Current status in forenal aneurysms.
Thanks. Mike, thank you again for the honor of participating today. So no disclosures. These are the FDA-approved stent grafts and those that are commercially available. The ones that are highlighted in red have been discontinued commercially, Anchor, Anurex, and the Medtronic Talent. The Lombard Medical was FDA approved in 2013, but it's not currently commercially available in the United States. I point out that in addition to this timeline, what's unique about this is the Trivascular Ovation FDA approval in 2011, which was the first time that there was a humanitarian device exemption approval for a device that was predicated on a subset of patients that included very small access vessels as well as a small proximal aortic diameter, the first time that had ever occurred. And then they received full FDA approval in 2013. So this is what, the landscape looks like in the United States. So a little bit about the clinical trial and commercial experience with EVAR. You've heard about this before. We know that the immediate EVAR outcomes are comparable and or even superior to those obtainable with open surgery. You heard about no ICU, no blood transfusions. There's the PVAR option that many of us are using routinely. Length of stay is now down to often less than 2 days. In some cases, people are exploring outpatient PVAR. Certainly, you can expand the therapy to patients that are deemed too high risk for open repair, but this is a bit of a double-edged sword, and you really have to select your patients honestly and carefully. And in fact, post-discharge full recovery usually occurs in about 7 to 10 days. Although inpatient costs are reduced related to savings on the length of stay side, these may be offset by high device-related costs. One has to be very aggressive in negotiating EVAR pricing. And this is a slide that many of you have seen before, but this goes back to 1997, and if there was ever a case for peri-procedural outcomes following EVAR, it's this one. I remember this gentleman asked me what his limitations were. He's the one in the middle, and I said, I can't think of any, and within 6 weeks he sent me this slide. What about commercial volumes? Mike asked me to talk a little bit about where we are in terms of commercial penetration, and in 2015, approximately 133,000 EVARs were performed worldwide. EVAR utilization is higher in the United States for EVAR for aneurysm repair. Probably the penetration is more than 75% compared to a bit of a more conservative approach in Western Europe where the penetration is about 52%. The U.S. currently represents probably greater than 50% of market share. Global market forecasts project 5.5% growth of EVAR per year, and the largest global gains are likely to be in China and India, whereas those in the U.S., Western Europe, and perhaps Japan remaining somewhat flat. Going back to 2012, EVAR in the United States was performed in about 47,000 cases, and certainly the current U.S. endograft market is valued at about $650 million, and it's growing at about 8% per year. Well, is EVAR durable and is it a curative option? Well, clearly in some patients it is. This is an 86-year-old man that I did an EVAR with an Ancure tube graft on 18 years ago, and I still see him once a year. And we know that in fact, in properly selected patients, EVAR is a durable and curative option. Well, what about some of the dark sides? Well, the long-term outcomes with commercial devices are better if physicians actually follow the IFU, and if you really pay attention to the IFU, anatomic applicability for infrarenal EVAR is probably in the range of 50%. Some of the next few bullet points are Andy Schanzer data. Endoleak may occur in 1/3 of all EVARs. There are the type 2 endoleak problems. Sac enlargement may occur in 21% of endoleak patients, and sac enlargement may be as high as 41% at 5 years, and this probably is reflective of the liberal use of EVAR outside the IFU. There's the incidence of device failure necessitating revisions, as exhibited here. This is one of my patients that I did an EVAR with snorkels on 6 years ago, and she's now 95 years old, presented with a rupture last week, and I was able to easily repair her percutaneously, and remarkably, she went home 2 days later. So talk about palliative aortic care. There's a need for lifelong surveillance. I mentioned the overall costs, if you look at re-interventions, are greater than open surgical repair, and in some publications, there's a bit of a higher AAA mortality with EVAR, as demonstrated here, and late rupture does remain a concern. Well, what's the etiology of late EVAR failure? Well, there's progressive dilatation of the pararenal aorta, producing potentially a 1A endoleak. This may be with or without migration associated with sac expansion. There's progressive dilatation of the common iliac arteries, producing a type 1B endoleak, as illustrated here. And late EVAR failure may be due to type 3 endoleak from material failure. There are other known etiologies of EVAR failure. These are typically more midterm rather than late term. We don't see much migration anymore as much as we used to. There's stent graft infection. There are unresolved type 2 endoleaks and sac expansion. There are multiple etiology endoleaks. There's endotension. And certainly there's graft limb thrombosis. This is a slide that I put together and I've updated periodically, but if you will, it's a timeline of limb thrombosis or limb occlusion associated with many different devices with follow-up from 1 to 5 years. And if you look at the range of limb occlusion, it's as high as 40% early on, but it doesn't necessarily end early on with the Ancure device. We've seen limb thrombosis with some of the newer technologies. And in fact, there are, with other devices, very low rates of limb occlusion and limb thrombosis. Is this device related or is this patient related? We're treating patients now with small aortic bifurcations and small access vessels, probably a combination of both. What about elongation of the aorta from the SMA to the aortic bifurcation? This is probably also a midterm failure mode, and we see this in patients and the resulting anterior bowing of the infrarenal aorta over time. What about solutions for these failures? Well, endovascular solutions are usually successful. It's not hard to put a proximal extension, extend the seal, and in fact snorkel the visceral vessels. We know this works, and you're going to hear more about this from Jason. If you have a reasonable trunk length and paying attention to the flow divider of the device, you can use fenestrated and branch devices to correct these late failure modes. And you certainly can either extend to the external iliac, or now in the United States we have a commercially available iliac branch device that enables us to manage 1B endoleaks late. And we certainly can reline grafts when there's material failure with AUI devices as well. I want to spend just a couple minutes keeping to the time here looking at re-interventions, and we recently looked at re-interventions at Penn over 16 years for about 1,800 plus patients. We divided these into FDA-approved devices and investigational devices over the 16-year period, and our overall re-intervention rate was 7.5%, and re-interventions were typically higher in the trial patients than they were in the FDA-approved devices, and this was consistent through the entire 16-year experience. What's a bit sobering about this is that even out to 8 years with FDA-approved devices, we are seeing reinterventions and, in fact, multiple reinterventions, again emphasizing the need for long-term follow-up. What types of reinterventions are we doing? Well, the most common in our practice is for sac expansion due to type 2 endoleaks, and this was consistent in both FDA-approved devices as well as trial devices. A lesser incidence of repair of type 1 endoleak, a higher incidence in our FDA population, probably because we weren't paying enough attention to the IFU as compared to the trial devices. And in fact, a higher incidence of limb interventions in our trial patients, which is consistent with some of the data that I showed you earlier. These are the procedures that we've used, and they are what you'd expect them to be. Translumbar embolization for type 2 endoleaks, relining, if you will, iliac angioplasty and stenting for the limb occlusions, and distal extensions or proximal extensions as well for type 1 endoleaks. What about the need to explant? Well, certainly the number of reinterventions in our experience was significantly associated with the need for explant. Trial device, etiology of reintervention, and type of reintervention were not predictive of the need for explant, and freedom from all-cause mortality did not differ based on whether it was an FDA-approved device, a study device, or need for explant. So in conclusion, we believe that long-term, consistent, and I'll say total aortic surveillance is essential to identify long-term EVAR failures before rupture. Most of these repairs can be done with simple endovascular solutions. Reinterventions are certainly less likely if you follow the IFU and you adhere to it. And given the excellent short and long-term results of ZFen in our practice at Penn, we are more likely to move to a fenestrated design rather than push or challenge the IFU with an infrarenal device. Thanks.
Going to invite up next for the home team, Jason Lee, who will be talking about the parallel branch grafts using the politically correct term and not snorkels, chimneys, periscopes, chimps. Jason.
All those things. Thanks, everybody. This is a real pleasure to be here and a real tribute for Mike Dake to have really assembled a room full of world experts and the people that came up with this. Because of some historical facts. So I actually was a medical student in 1995, and Tom Fogarty and Chris Ahrens came down to Harbor UCLA to do Anurex case number 2, and so I actually was the medical student on Rod's service when that happened. So that's 22 years ago, but that had always sparked my own interest in this, and so it's really a pleasure to be here and to see all of the folks and have worked with many of you in the room over the last 2 decades. So I think I have the best job in the world because while a lot of you guys are influenced by Mike, I actually get to work with him every day. And so we do cases together. We spend, this is in the new hybrid room at some point when the first case set up. And, so I think it was a real tribute yesterday when the folks came out early. And Mike and I decided not to golf because the last time we actually golfed together was a pretty terrible day. I think we lost multiple rounds of balls, and we had to pay for like a pro to be with us, and there was no helping our game really. But that was the last time we golfed. So yesterday, I think the real golfers went out to spend some time with our guests golfing. Mike drove a golf cart around and gave some tours, and I took some people over to play tennis. So that was yesterday. Historically, parallel grafts, actually was first described by our Cleveland Clinic colleagues, and Roy had noticed that in trying to raise the infrarenal neck, particularly when the fabric of a stent graft encroached upon the branch vessel, really kind of came up with the concept. Now back then, it was just sort of self-expanding bare stents to really push the fabric over to continue to perfuse this side branch, and really this was to ensure that the graft material was as close to this infrarenal neck as possible. This is probably one of the most famous illustrations now that everybody sort of utilizes in these introductory talks, and actually Dr. Krazier's in the audience too. He was sort of on this original description, and so everybody had this theoretical idea that you would have this covered stent that would push away the fabric and things would mold around, and they found this useful in about 6 juxtarenal cases. Many of them were ruptured and urgent and could not get a some sort of custom device, which actually back then outside of US they had full access to. So many of the early sort of investigators that thought about this process really felt that this was for the urgent, emergent, ruptured, salvage procedures. Over the years, then, because of some limited access to Z-Fen here, or the amount of time that it took for the device to get through the regulatory process, several groups really started to look at this as a more sort of purpose-specific build, and so we included, started to, purposefully, in a prospective fashion, track our outcomes related to these parallel grafts. And so the current series for us is now 96 patients, covered stents, purposeful, meaning planned from the outset. And we've had over this 6 or 7 year period, 98% technical success, 2% 30-day mortality, and followed out to 3 to 4 year follow-up, 96% primary patency. And like many of these patients with juxtarenal aneurysm, survival decent at 1 and 2 years. And this has been sort of our general strategy, is to get the fabric as close to the SMA as possible, and then mainly have focused on dual branch chimneys, meaning just for both renals. And also, interestingly, in this depiction, always having a slight infrarenal neck, even if it's millimeters, probably helps the long-term outcome, particularly related to gutter leaks. So this sort of interest, of ours generated a lot of long-term concerns, and so we spent quite a bit of time the last several years looking at issues related to renal patency, the second interventions related to placing parallel grafts, gutter endo leaks, and then problems with sort of migration and kinking of these branch grafts placed in a parallel fashion. Frank Vieth, I think it was at towards mid-2015, encouraged several of us to put together a worldwide registry, which we did. And through the help of Frank Criado, that's also in the audience, put together several centers series that had all done more than 20 or 25 cases. So we came up with 517 patients we followed with nearly 900 parallel grafts placed with a follow-up of about 1.5 years, and found primary patency to be about 94% with a sort of persistent gutter endo leak rate of about 3%. And this really helped us to sort of convince the folks that were interested in sort of applying this technique that there was some decent short-term follow-up related to this. Followed out further, 2.5 year follow-up, when we looked at patients that had at least that was about half of the patients, so 244 patients and nearly 400 chimney grafts. Followed out to a mean time now of nearly 4 years. The patency is about 94%, which then by the Kaplan-Meier sort of estimates out to 5 years, when we dropped to only 33 that were able to follow, down to about 92%. So still relatively good midterm patency at 48 months. Sac shrinkage, this is obviously a chosen patient that we followed with pre-op and then out to 3 year follow-up. But when it has worked well, then it has sealed the aneurysm well, and sort of averaged out for all of the patients. The mean sac regression has been several millimeters over time. Now, how about these gutter endo leaks? And this has perhaps been the bane of the existence of this strategy, is this sort of creation of gutters. And so we followed this pretty closely, both in the Pericles registry, about a 6% rate, requiring half of them to have a second intervention, mainly reaccessing of the snorkel grafts and or some sort of sac embolization or gutter embolization. When we looked at risk factors for this, and this sort of gets back to whether there needs to be an IFU, if you will, for this strategy, that then it actually turns out similar, I think, to both standard infrarenal EVAR, that the larger the native neck diameter and the more likely that you're pushing the envelope of having a larger device is probably the main risk factor for problems related to gutter endoleaks. And some people would argue that a 30 millimeter infrarenal neck is probably the beginning of a diseased neck, that over time, if we sort of believe that these devices continue to cause dilation as well as sort of the disease progressing, that there is this long-term chance of this happening. And certainly the absence of it, so any sort of infrarenal neck was also a risk factor for these type 1A endoleaks. So a lot of people have then looked at some other ways to find sort of the best conditions for this. Vincent Rambaugh is here, and he had designed sort of several elegant studies to look at what are the best sort of conditions for these parallel stents. And then we have looked long term at whether these gutter endoleaks actually get better, and it turns out that you can divide them into both long and short endoleaks. The short endoleaks sort of occur just around the seal zone at the top, but because there's an infrarenal neck, perhaps that gutter actually doesn't continue to perfuse the aneurysm, and those are the ones that we've been able to watch that sort of successfully go away. Chris Chang's in the audience. We've also spent a lot of time with him looking at sort of conformational changes with sort of breathing patterns, and looking at both when you have stent grafts that are in parallel fashion versus fenestrated, what that means. And we've looked at different radius of curvature as it gets out to the distal renal. And still sort of trying to understand some of the boundary conditions for long-term why these branch grafts fail. This is a 7-year follow-up of one of our early patients, just to sort of document that we're still tracking a lot of these folks long-term. There's actually been complete regression of his 7-centimeter aneurysm, and these are the images on sort of cross-section where the snorkel grafts sit in place, and he's had excellent renal function long-term. So what's been happening sort of overseas? Donas has really sort of pushed the envelope of working with Medtronic to come up with kind of a single device and a single strategy for this. This is his Protagoras study that showed excellent long-term outcomes that actually wound up leading to CE mark for the Endurant device with a parallel graft. And this happened this past winter, and so we'll be very curious then long-term, or certainly in the next 12 to 24 months, whether there's any uptick in this. But really, I think probably the elephant sort of in the room has always been for these short neck renal, or for these short neck infrarenal patients, were we really just waiting for access to fenestrated devices? And certainly, I think everybody knows this was approved in July of 2012. We spent a lot of time debating between sort of the techniques. This is what we've done since the approval. It's really sort of reserved the parallel graft techniques for the urgent cases or for migrated primary devices. And certainly we're voting with our feet here that if we're able to fit an on-label fenestrated device for it, that's what we have supported. Fortunately, or perhaps sometimes unfortunately, they all don't look sort of perfect like this, that there's a short neck infrarenal, and then there's not a lot of angulation in this, and these devices fit in well. So I'll sort of conclude with how we've sort of approached this. Now, certainly the patients that have low physiologic risk, we still every once in a while consider for open surgical repair. But really, a lot of the referrals, and certainly probably similar to a lot of people's practices in the room, you're getting patients referred that are medium and high physiologic risk. And I think that patients that are short neck, if they can fit an on-label fenestrated device, that's been our go-to device. And then in the high-risk patients only, the urgent emergent repairs, significant downward going renal angulation, or for bailout situations, I think that we found that the chimney approach has worked well for that. Thanks.
Okay, thanks, Jason. So next up, and Jason's talk is a nice introduction, is to Eric Verhoeven, who's going to talk about fenestrated and branch grafts for the abdominal aorta.
Thank you very much, and Mike, thank you very much for this excellent organization, but also to take such great care of us. So my task is to talk about fenestrated and branch grafts, and I can't do that without disclosing my excellent relationship with Cook for now also almost 20 years. And to start my presentation, I would like to summarize modern medicine, which has also changed in two very short videos. Modern medicine is characterized by cooperation, social behavior, open discussion, and we are not at all afraid to show each other the way when something doesn't go right. And the next thing is that modern medicine is characterized by ever more technical acts, and the technical execution is not always good, but this video seems to demonstrate that at least the technique works very well. So with that, we can move to vascular surgery and endovascular surgery. As you can see from the right slides, this is where we work now. These are our two hybrid rooms where we do all of our cases. And it's very much true that endovascular repair really catalyzed this development. These are my two first standard EVA patients. On the left, you can see the list of expected advantages. This was in 1995. And on the right, you see the patients indeed playing pool in the evening after their procedure instead of lying on an ICU. Now in the Netherlands, like in England and in the US, we did a randomized trial to demonstrate the advantages of EVA, but we also had to learn about the downgrades. And the downgrades were related to technically imperfect grafts in the beginning, but certainly, and we heard it before, due to wrong indication or wrong technical execution. I think, as Ron said before, we still underestimate the need for a decent and suitable proximal neck. And it's not only the length, it's also the quality of the neck. And the one thing that hasn't been said is that aneurysmal disease, at least often towards the renal arteries, can be progressive. So we continue to see these type of pictures. On the left, an aneurysm, in my opinion, that is completely unsuitable for standard EVA, was still treated with EVA, and after 5 years we have to deal with these complications. So to summarize, we have to learn the limitations, and we shouldn't jump too far, because here it's only the jumper who pays the price, but in our case it's really the patients who pay the price. So we have to be a little more careful. And my task is to talk actually about all those patients that are completely non-suitable for standard EVA, and they are shown here on the picture. You know all that the first proposed solution, now almost 18 years ago, was the fenestrated graft. In other words, to customize holes in the stent graft to fit the visceral arteries. And the goal of fenestrated EVA is really to turn an absent or very short neck into a long neck, and that's probably very important. The technique as shown here by the original Cook video was of course not elaborated that well in the beginning. Here you see the composite system. It has been discussed before. From the contralateral side you catheterize the fenestrations. You have to be able to reposition the graft. Once you are safely inside, you can open the graft completely, stent the fenestrations, flare the stents, and from there it is then standard procedure. You add your bifurcated portion and a contralateral limb. But I would like to commend Cook for putting so much effort in the development in this technique, but also to allow all these protagonists to meet twice a year. And I think that is what made the technique successful, that in the beginning years we met once in the States and once in Australia to discuss all the technical refinements and to develop the technique further. And the one person that really needs to be mentioned is Roy Greenberg, who joined that group maybe a bit later because he was much younger, but who blew us away with his brilliance and his technical refinements and helped the technique forward. Just a few little items. I told you, you have to reposition a graft. I still see people opening a graft and then trying to catheterize. No, you have to reposition each hole towards the target vessel to allow catheterization. And this is thanks to the diameter reducing ties, which will allow you to reposition the graft. We know that we had to stent. Initially, we thought we should stent to guarantee re-access to the vessel if needed. But now we, of course, stent to guarantee perfect apposition of each fenestration to the ostium of its target vessel. And we use covered stents because they perform better, they are stronger, they keep the fenestration position, and when needed, they also provide a seal. The reinforced scallops came up because an unreinforced scallop is the weakest part of an oversized graft and then shutters down logically and could create some problems. And this is not the case anymore with the reinforced scallops. We reinforced the small fenestrations to guarantee a better base for the covered stents to be flared and to guarantee better sealing. And then we moved forward, of course. We didn't stop there. We repaired failing EVAR patients. We published on that subject. You can see a very difficult anatomy that was shown before. We were able to reline this completely with a fenestrated graft to exclude the aneurysm. And this is probably my favorite patient. After many previous operations, the man presented with this anastomotic aneurysm after open surgery on his aorta, and we were able to treat him with a fenestrated graft under local anesthetic, and the patient did very well for about 9 years until he died of other reasons. And then, of course, we moved upwards into the aorta. We started using triple fenestrated grafts and quadruple fenestrated grafts to treat also suprarenal aneurysms and some type 4 thoracoabdominal aneurysms. We compared the more complex fenestrated procedure with the standard procedures, and we were able to demonstrate that we can now, with experience, with team effort, with the modern hybrid rooms that we have, we can do these more complex cases with the same low mortality and morbidity. And actually, and this is maybe important for the US, the double fenestrated graft or the standard fenestrated graft has virtually disappeared in Europe in favor of using a triple fenestrated graft. In other words, we are not afraid of stenting the SMA, creating an extra fenestration for the SMA to gain a longer sealing zone and probably even longer durability. And it's not only because we treat more complex cases, because if you look at the sealing zone that we create with our fenestrated stent grafts, you can see that it moved up from roughly, with or without a scallop, these are the two bars, from roughly 3 centimeters to about 5 centimeters. And if you would go into the chimney graft publications, you will see that the sealing zone they create is 15 to 20 millimeters. And if sealing zone is a landmark or marker for durability, there is no doubt that in the patients that can or that are suitable for fenestrated graft and that can wait for the fenestrated graft, this is the better option. This is just a quick paper because, and I'm showing this because this was the first paper that had it as a title, first line treatment, because we propose this for every patient that is suitable. It doesn't mean that we don't do open repair, but at least we discuss fenestrated EVA. And this patient included, this paper included 281 patients. The update up to now, we've done 430 patients with a mortality of 0.5%. New kids on the block are welcome, even if they don't all remain like the graft on the right side because of patency issues. The Anaconda on the left side is used frequently in Europe, presents with some potential advantages because you can close the graft completely and because you can easier get an access from above, although we can manage that with the fenestrated graft from Cook. I personally don't use it because I don't like to seal on just 2 rings. I prefer a longer and stable sealing zone. But it has been used with success and with good results up to now. A final word on the further evolution towards repair of thoracoabdominal aneurysms. In the beginning, it was performed with 4 fenestration grafts, but we understood very quickly that we need another type of solution with branches here. And of course, Tim is in the room and is really, so to speak, the godfather of the branched graft technology. And with that technology, we were able to treat patients that would otherwise not have a chance to be treated by open means. This old man with a very large aneurysm after previous open surgery. Also here, development, the indwelling catheter that facilitates the job, the branch technique with tapering the main graft to create some room for the branches so that they cannot be jammed in an angulation. Here also an example of grafts with both branches and fenestrations, if the anatomy requires it, and something we've been using for the last 2 years, publication to follow, is the so-called inner branch, which means that you have the branch completely on the inside of the graft, which allows you to keep your main graft against the wall and to create a longer sealing zone. We moved forward. We now treat post-dissection aortic, thoracoabdominal aortic aneurysms. This is just an example of the so-called full metal jacket. And because Cook provided us with an off-the-shelf 4-branch graft, we can now also treat acute patients and patients with contained ruptures, as you can see here. Did we learn lessons? Yes, even with this technique, there are limitations. We saw in our experience that the very old and frail patients, so to speak, the ASA4 patients, don't do very well. The early mortality is much higher and the late survival is much lower. So there is a limit also to this technology. And it's very difficult to say no to a patient that has been referred to you as a last resort, but I think there are patients that probably should not be treated. So are there conclusions? Well, I think the fenestrated and branch procedures are here to stay. Here you see our overall tableau. I've now done about 1,200 of these cases. We do about 140 a year. So I think this technology is here to stay. But it remains very much true that with all the technologies that we now have, it is very important to choose the best option for the patient based on the aneurysm characteristics, on the patient characteristics. And at this time, I think the patient also has a little word to speak. And to finish, following Christoph Nienaber's cheetah, I found another one to say that we shouldn't chase the patients, but we are here to help the patients. So there is always a solution, as you can see. And with that, I would like to thank you for your attention. Thank you very much.
I'd like to invite up next Dr. Macaroon, who will be discussing fenestrated and branched endografts for the thoracic aorta.
Thank you, Matt. Since I really don't have a whole lot to say about the aortic arch branches, and since this is a celebration really of sort, I thought it would be quite important to toast a little bit Dr. Dake, who has managed to be a teacher to most of us and put this Festgraft together. And 25 years ago, did the first U.S. Stent-Graft in an aneurysm. We have all learned a lot from him, but we also are mostly grateful for being his friends. One of the problems of being the friend of Mike Dake is it comes at a cost. You feel quite inadequate being close to him. He is not only a radiologist, internist, pulmonologist, art collector, bon vivant. He has probably the best taste in wine and knows all the best restaurants in the world. You keep wondering, how can we keep up with him? He's the only person I know with a Black American Express. He has more miles accumulated on more airlines than all of you combined. So finally, I was gratified to find that he cannot troubleshoot one thing. And I want to share it with you so you don't all feel as inadequate with him as I do. And that is, he cannot troubleshoot a malfunctioning boat. And this, and this is actually a boat that he rented in France. And you can see the T-shirt of the Warriors after they won their first World Championship. And within 4 days, he turned it into the picture on the right side. So there is hope. He is a little bit infallible. So he asked me to talk mostly about the current status of branch TVARs in the arch. And these are my disclosures. You are all familiar that open arch reconstruction is somewhat of a morbid operation which carries certain mortality and morbidity, but more importantly, many patients are excluded because of this mortality and morbidity. And that's why we always search for alternatives such as debranching through a sternotomy or the use of parallel graft, and more recently, the direct endovascular arch reconstructions. A couple of quick results. This is a meta-analysis of the hybrid repair compared to the open repair, and it shows that it does improve the mortality a little bit, but actually does not improve the neurologic deficit results all that much. These are a few papers about the chimney techniques in the thoracic arch, and in general, they are still associated with a significant type 1 endoleak rate and a high reintervention rate. We have to introduce them to Dr. Lee so he can help them with this. In terms of history, the first I could find in terms of a published report about the branched placement of an end graft was actually by Dr. Inoue from Kyoto. And he actually started by suggesting a single branch device that goes into the subclavian artery before he actually came up with the 3-branch device. And this is the paper that was referred to by our Japanese Doc is here. He mentioned that they had 19 of these patients, but actually this paper includes only one of the 3 vessel of the 3 chimneys, and the 18 were done with the single branch device. This is a few years later. Dr. Schuder used actually the single branch device all the way into the innominate with a complete debranching of the neck, describing the procedure. And this is the device that he described that is introduced from the carotid or innominate with the reconstruction following from the groin. There has been a variety of possible solutions that have been suggested for dealing with the arch branches to come up with a complete endovascular repair, including custom-made scallops or custom-made fenestrations. There has been an interest in situ fenestration of a graft that is placed directly into the lumen and then approached from the branches. And as mentioned before, the 3-branch system. This is a brief review of the in situ fenestrations. Of course, there's been probably a lot more than the 73 procedures described here, but not all of them are published. And the technical success rate is high, but the mortality is still not negligible. In terms of the custom fenestration, This is a report from Hamburg about 15 custom fenestrated endograft compared with 14 branched. And I just highlighted something that has been plaguing essentially all of the branch interventions in the arch, which is the stroke rate, which in this situation was about 13%. With a mortality of 20%. It's also of note that all of these reports typically deal with high-risk patients and more urgent type of procedures. In terms of the potential commercial off-the-shelf branch TEVAR systems that are being studied and potentially may come to market are the two solutions that deal mostly with internal branches, with two internal branches, and that's the device from Bolton and Cook, and both of them have internal branches that are approached from the cerebral vessels, extending the branches into the cerebral vessels. And this is an early report that I could get from Dr. Jan Bau's review of the Bolton relay device, citing a high success rate, but still a significant endoleak rate, stroke rate, and mortality. The experience with the two-branch device of Bolton shows here the complication and the stroke rate of about 8%. In terms of the Cook device, this is the early report that Stefan published in 2014, about 38 patients, and you still have a mortality of about 13%, an early reintervention rate of 10%, and a stroke rate of about 16%. A follow-up review showed actually a improvement in the mortality and the technical success rate with more experience with the device, but unfortunately the stroke rate and the reintervention rate remain high. In terms of the single branch systems, there are two that have undergone testing so far, the Medtronic Mona Lisa and the Gore TBE. And these are some early published reports showing a high technical success rate and very low mortality. Briefly, the Gore device has either an 8 or 12 millimeter diameter and is intended to be used either in the subclavian or all the way up to the innominate. It has a specially designed side branch component and it is pre-cannulated. This is an example of one of my patients with a type 2 deployment with a 6.6 centimeter device. It's aneurysm. The device is advanced over two wires, one in the subclavian and one in the aorta deployed, and the branch is then inserted, confirmed, and this is at 1 month. This is at 6 months. And this is a zone 0 patient that has undergone already the neck debranching of carotid subclavian, followed by the introduction of the device, deployment, and then the side branch in place, feeding the entire cerebral circulation. Briefly, some of the results from the early feasibility study. The access was quite successful, and so was the deployment and the procedural survival, with a procedure time that is about 3 hours or so. Mean length of stay was dependent on the zone that this was being deployed. There was 1 stroke in the zone 2 at 1 month, and 2 strokes in the zone 1, illustrating again probably the Achilles heel of all work in the arch with branches. The reported endoleaks, there were a few early endoleaks, but all of them subsided without interventions. This is the side branch patency. There was 1 asymptomatic left subclavian branch occlusion at 6 months that was noted just on imaging. I think I lost the rest of it. Essentially, there's some encouraging results, but again, the disappointing part are the strokes that keep happening, although they're not necessarily very frequent in this. This early trial has encouraged the development of a large pivotal trial that should provide us with a lot of answers, both about this device as well as the deployment of branch systems in the arch. The maximum potential enrollment is about 435 patients, and so far 65 have been enrolled as of a couple of weeks ago. Thank you very much, and I think that should be it.